Assalamu alaikum. Now, now I would like to discuss about serotonin syndrome and neuroleptic malignant syndrome. First, start with my intro. Can you hear the murmur? Can you tell me the name of this murmur? Okay, let's go with a story first. Tell me, what is your diagnosis? A 44-year-old man is brought to the emergency department after he was found talking to himself in the park. When the authorities ask him to leave, he becomes agitated and combative, saying that he was destined to lead and has to wait in the park for the sign. Okay, the patient admits to not sleeping for the past week. His thoughts jump from topic to topic. He appears distractible, disorganized, and unable to care for himself. The patient is admitted to the hospital and prescribed daily haloperidol and valproate. He is prescribed daily. Look at the look at the drug. He is on haloperidol. He is on haloperidol and he is on valproate. Valproate. Okay. Over the next week, he becomes significantly calmer, and although he continues to believe that he will lead a spiritual revolution, 10 days after the admission, the nurse staff members find lying in the bed, confused, temperature is very high, near about 102, BP is 160 by 90, pulse is 122, and as a precaution, all the medications are stopped. If patient condition fails to improve with supportive measure, what will be the medication would be the most appropriate for this patient? What is your thought? Okay, take a 5-second break and think. So it is NMS, and that means it is neuroleptic malignant syndrome. Okay, if you look at these box in neuroleptic malignant syndrome, first of all, according to the story, I have thought patient is on antipsychotic like haloperidol. On mm, patient is on valproate also, valproate, which is an anti-epileptic drug. So he is on antipsychotic, not antiemetic. So in NMS, the causative agents are antipsychotic, antiemetic like promethazine, and withdrawal of Parkinson medication. There is pathophysiology, central dopaminergic receptor blockade. There is hyperthermia. This patient has 102 temperature, hyperthermia. There may be dysautonomia and dysfunction of the nigrostriatal pathway. So neuroleptic malignant syndrome, nigrostriatal pathway, neuroleptic malignant syndrome, nigrostriatal pathway. Cancer signs, there will be fever, this patient has fever, altered mental status. This word is very high, like late pipe rigidity. NMS patient comes with these late pipe rigidity. There will be autonomic instability and elevated CK with a renal failure. First treatment, like in this patient, we have stopped all the medications or restarted the dopamine agent. Supportive care, hydration, cooling should be done, intensive care unit. And the next thing you should do benzodiazepine and bromocriptine or dantrolene can be given. Bromocriptine or dantrolene can be given. So this is atypical like bromocriptine. Uh, Bromocriptine is used for if there is pituitary adenoma or like if there is excess lactation, then we can use the bromocriptine for stopping the lactation. But in here we are using for NMS. Dantrolene can be used, bromocriptine can be used if refractory. So as this patient As this patient, we have stopped all the drugs. Now we can use either benzodiazepine or bromocriptine. Okay. It is idiosyncratic, not dose dependent. Very high yield. It is not related to dose. Like if you give high dose, then it will cause neuroleptic malignancy. That does not goes according to this. So autonomic instability, there may be diaphoresis, tachycardia, diaphoresis, tachycardia, tachypnea, dysarrhythmia. There may be muscle rigidity, lead pipe rigidity, there is fever, altered mental status. These are the features we find in the neuroleptic malignant syndrome. And NMS, and in in serotonin syndrome, it is similar to NMS. It is similar to NMS and will have shivering, hyperreflexia, myoclonus, ataxia, and also it it is acute less than 24 hours, versus days to weeks, like days to weeks. Like this patient, our patient, it happened 10 days later. If it is happens within the first, within 24 hours, if it happens within 24 hours, then you can tell that it is serotonin syndrome. Because okay, I am giving you another scenario, like a 33-year-old man hospitalized for depression versus with psychotic. Okay, he was started citalopram and risperidone. He was started citalopram and risperidone and admitted to the inpatient. He is admitted to the inpatient. Okay. Okay, so this patient has, like, this in this scenario, in new scenario, temperature is high, 102.9 degree Fahrenheit. Like, tell me the diagnosis. 102, BP is 160 over 80, pulse is 118, respiration 60. On examination, the patient is disoriented and unable to attend the interview. He has severe muscle stiffness but no hyperreflexion. Very, very, very important. He has muscle stiffness but no hyperreflexia. If it is hyperreflexia, what is your diagnosis? Tell me. Serotonin syndrome. Uh, as this patient has muscle stiffness but no hyperreflexia, think about NMS. Okay, okay, I'm giving you another scenario. You tell me what is your diagnosis in that case. A 30-year-old woman brought to the emergency department by her sister after developing an anxiety headache, nausea, vomiting while eating dinner. The patient has no history of migraine, hypertension, or diabetes. She has no known food allergies but does not have a history of seasonal allergy treated with diphenhydramine. The patient has a long history of MDD and panic attacks. For the past year, she has been treated with escitalopram. First thing, the first thing you have to look at the escitalopram, which is antipsychotic. It's a second generation antipsychotic, which she discontinued a week ago. He discontinued escitalopram. Okay. Okay, she started taking phenelgin for depressive symptoms. On arrival, she's agitated, disoriented. Look at this point. Like, if you switch a new drug, you need to taper the SSRI. You cannot just suddenly stop and start uh, it. On arrival, the patient is agitated, disoriented, diaphoretic tremulousness, and he's hyperthermic. Blood pressure is like this, and pulse is again high. Physical examination. There is dilated pupil. There is dilated pupil. There is bilateral tremor, and deep tendon reflex are 3 plus. Their deep tendon reflex are 3 plus. Which of the following would be your diagnosis? It is serotonin syndrome because he is on SSRI. So If you think about serotonin syndrome, serotonergic medication, especially in combination with SSRI or SNRI, TCA or tramadol, drug interaction, serotonergic medication, MAO or linezolid, intentional overdose of serotonergic medication and serotonergic substance, MDMA, dexmethorphan, amphetamine. There may be mental status change, there may be autonomic change, there may be neuromuscular hyperactivity, tremor, myoclonus, and hyperreflexia. Again, like in MS, in here we should be discontinuation of all serotonergic medications, support and sedation with benzodiazepine and cyproheptadine, specific antagonist for serotonin syndrome. If supportive measure fails, an immediate sedation, paralysis, and tracheal intubation. If if temperature, if serotonin syndrome, tracheal intubation should be done if temperature is more than 106 or 41. Then you should do what? You should do tracheal intubation. So patient is taking phenelgin, which is a monoamine oxidase inhibitor used in treatment for treatment resistant depression. MAO irreversibly inhibit monoamine oxidase and preventing the oxidative deamination of the serotonin, norepinephrine, and dopamine. Her acute symptoms of agitated delirium, these and that, are consistent with serotonin syndrome. Most likely, it is a drug interaction between the phenelgin and the acetylopram. The SSRI she discontinued a week ago. Serotonin syndrome is caused by excess serotonin level and is characterized by triad of what mental status. Serotonin syndrome is the man. It's a man like a mental status changes, autonomic dysregulation, and neuromuscular hyperactivity. So in serotonin syndrome, you will mental status changes, autonomic instability, dysregulation, and Neuromuscular hyperactivity. Okay, the last. So you have to look at the drugs you have to look at the drugs along with the features. If you look at the drug along with the features, it is easy to diagnose this. Last scenario of these NMS versus serotonin syndrome, a 63-year-old man is brought to the emergency department. He came with the one main feature, all mental status. Altered mental status. He is restless, autonomic instability, altered mental status, restless. Temperature is high, 101. Okay, so this patient goes to the primary care physician for upper respiratory tract infection. The physician prescribed dexmethorphan. Dexmethorphan is one of the culprit. If somebody is taking drugs, fluoxetine like a serotonin drug along with dexmethorphan, and then there is hyperreflexia and ankle clonus. This is very high, like hyperreflexia and ankle clonus. For hyperreflexia and ankle clonus on neurological examination, think about serotonin syndrome, not neuroleptic malignant syndrome. So if acute status, I have a theory. If there is acute problem, go for benzos, which is an GABA inhibitor, GABA. And if it is a chronic problem like depression type of, go for SSRI. And that is all about the serotonin syndrome and neuroleptic malignant syndrome. Hope you enjoyed.